Good afternoon, and thank you for the invitation to speak. This is my disclosure. So in thinking about the optimal timing of surgery for Crohn's disease, we first have to look at the different indications for surgery in Crohn's disease and how they are done in both the elective, semi-elective, and urgent setting. And it's really the cases that are done in the elective and semi-elective setting for these indications where we actually have an opportunity to intervene. And so that's really what this talk will be focusing on. So why does timing of surgery for Crohn's disease matter? Well, it's really because delays in surgery and surgical referrals can often lead to malnourished and deconditioned patients and therefore increased surgical complications. And so it's important to identify these patients early so that we can minimize this risk. But in addition, some patients present with stricturing or penetrating disease, and oftentimes in these patients, we have an opportunity to operate in either the urgent setting or semi-elective surgery, semi-elective setting. And while immediate surgery may carry some risk, sometimes strategically delayed surgery may actually improve outcomes. And so let's talk about the elective surgery first. This is the medically refractory patient with inflammatory disease. And the dilemma here is that, in the era where there are multiple biologics that are available to us, oftentimes as surgeons, we refer patients that have had and been on multiple biologics before they finally get the surgical referral. And in this duration, the patients have had multiple exposures to steroids, and during which time they have lost weight, developed malnutrition, and sarcopenia. And we all know that these increase surgical complications. So the solution here, or one solution here, is an early referral and evaluation by a multidisciplinary team, including the gastroenterologists, surgeons, and a referral to a dietitian. And in doing so, we can identify patients that may proceed to surgery. We can improve the patient's nutritional status throughout medical therapy, but also as they're prepping for surgery. We can consider factors such as how we can minimize and taper steroids quickly. And in patients who are proceeding to surgery, surgical prehabilitation may improve outcomes. Now, some patients, in that setting, I discussed, patients that have had multiple biologics and potentially, stopping short of the next biologic before referral. But some patients can actually, or should actually be referred before they even start a biologic. And this was shown in the Lyric trial, which was a randomized study that included patients with non-stricturing Crohn's disease with short segment inflammation less than 40 centimeters of ileitis. And these patients were randomized to resection or infliximab. And in their primary endpoint, the authors found that surgery was at least as good as infliximab with respect to quality of life at 1 year. And in subsequent studies, they showed that surgery was actually more cost effective. And in the most recent publication, looking at long-term follow-up, patients who were randomized to infliximab actually underwent surgery ultimately in the follow-up period 50% of the time, whereas those who had gotten a resection or started on a biologic 26% of the time. And so the authors concluded, and I also agree with this, that considering surgery early in patients with limited medically refractory ileitis, in lieu of a biologic appears to be appropriate. Now let's look at, the semi-elective setting. These patients with fibrostenotic Crohn's disease, for example, who present with a stricture and an obstruction, oftentimes they will have normal inflammatory markers, and the ileal wall will have no hyperemia, suggesting that this is really a burnt out stricture. Patients will also have prestenotic dilatation or small bowel fecalization to suggest that this is a chronic, ongoing obstructive process. Now, we often jump to surgery, we often jump to steroids in managing these patients, assuming that there is an inflammatory component. However, many patients will actually resolve and improve with respect to their obstructive symptoms just with simple bowel rest and IV fluids. And so, minimizing steroid exposure in these patients that are potentially proceeding to surgery during that hospitalization is absolutely appropriate. But when possible, and when we can get the patient to resolve the obstruction without surgery, we can actually have the opportunity to improve and optimize surgical outcomes by then proceeding with nutritional optimization, surgical prehabilitation, and then scheduling the surgery in a semi-elective setting in the next few weeks. In addition, patients presenting with penetrating disease, such as an abscess or a fistula, can also be managed oftentimes in the same semi-elective way. We always recommend draining the abscess, starting antibiotics in those who have an abscess, tapering off any steroids, and then proceeding with surgical optimization, nutritional optimization prior to surgery. In patients with a fistula, if it's a high output fistula, sometimes parenteral nutrition may be appropriate, but again, you want to get sepsis control, achieve nutritional optimization prior to referring the patient to surgery, oftentimes coming back in an elective setting once the patient's been discharged from the hospital and better optimized in the next several weeks. Now, some patients come very malnourished. And in these hospitalized or severely malnourished patients, the question often comes up whether we should delay surgery in order to achieve nutritional optimization. And this is a controversial topic with conflicting data. Enteral nutrition does appear to be preferred in these patients over parenteral nutrition. A meta-analysis that looked at 1,000 Crohn's patients showed that in patients receiving enteral nutrition, postoperative complications were lower than those who did not. Parenteral nutrition, on the other hand, should really be reserved for patients who cannot have enteral nutrition. But if you go that route, then how long should you really give the patient parenteral nutrition before you bring them into surgery? And again, the data is conflicting. However, it appears that at least 60 days is needed to achieve some protection against non-infectious complications. However, other studies have suggested that there is no difference in postoperative complications in patients treated with parenteral nutrition versus those without. And there does also appear to be an increased risk of line complications. And so if you are delaying surgery, you really would need to delay it at least 60 days. And this may be very impractical. The shorter delay, on the other hand, appears to have less clear benefits. Alternatively, exclusive enteral nutrition may be tried in studies that have had exclusive enteral nutrition as a comparison to no EEN. There does appear to be a benefit if done for about a month with increased albumin, lower CRP, and decreased surgical complications in these patients. But again, EEN in these studies implies a feeding tube and really exclusive formularies that are used as nutrition rather than normal diets, which can be difficult to convince patients of when they are tolerating oral nutrition. So basically, the decision has to be balanced against other risks, both social, economical, et cetera. And then finally, I wanted to talk about the timing of surgery and biologic drug dosing. This has been an area of controversy for some time, with early data suggesting conflicting results. However, the Puccini study that was done a couple of years ago looked at multiple institutions that included 955 IBD patients, and the study compared those who received anti-TNFs within 12 weeks versus those who did not receive anti-TNFs. And the study compared infectious complications, and there was no difference really with respect to any infections and also surgical site infections. And even on multivariable analysis, anti-TNF use and drug levels was not associated with infectious complications. So they concluded, and I agree, that there's really no need to modify the timing of surgery based on a patient's recent use of a biologic. So to summarize all of this, really a multidisciplinary team should be involved very early in patients with disease that's refractory to the standard immunomodulating therapies, in patients with short segment, non-stricturing Crohn's disease. Surgery should be considered, in lieu of biologics. At least a surgical referral should be placed so that the conversation is flowing and available, and the patient has a relationship with a surgeon, a relationship with a dietitian who can help look at nutritional parameters so that when the patient does go to surgery, they have the best results. In those with elective and semi-elective surgeries, slight delays in surgery may actually improve opportunities to optimize nutrition, to allow a steroid taper, to obtain sepsis control in patients with penetrating disease, and to allow resolution of an obstruction prior to bringing the patient and doing an operation. And finally, to emphasize that there's really no indication or need to delay surgery in order to time it appropriately with the patient's biologic drug dosing. Thank you.